Hello, everyone, and welcome to today's webinar, Connected Technologies for Improved Access in Global Hearing Care, presented by Professor DeWitt Swanepoel, Ph.D. from the University of Pretoria. Before we begin, I'd like to go over some items to help you participate in today's webinar. When you join today's webinar, you selected to join either by phone call or computer audio. If you would like to change your choice, you can do so by accessing your audio pane in your GoToWebinar control panel. If you have a slow internet speed, we do recommend you listen via phone and not over your computer speakers. During the presentation, all participants will be in listen-only mode. You will have the opportunity to submit questions to today's presenter by typing your questions into the questions pane of the control panel. You may submit your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. This webinar is being recorded and will be posted to the CAA website within 1 week. CAA webinars do count for continuing education credits. And now we would like to thank CAA for sponsoring today's webinar. I would now like to introduce our host for this session, Melissa Polanenko. Melissa?
Hello, everyone, and welcome to today's webinar. My name is Melissa Polanenko, and I am very delighted to be your host today and to thank you for taking the time to listen to our prestigious speaker present Connected Technologies for Improved Access in Global Hearing Care. Dr. DeWitt Swanepoel is a professor in the Department of Speech Language Pathology and Audiology at the University of Pretoria, South Africa. And his research capitalizes on the growth in information and communication technologies to explore, develop, and evaluate innovative service delivery models and applied solutions to improve access to early development and health services. Dr. Swanepoel also serves as the current president of the International Society of Audiology. I'm very excited that he is presenting today, and Dr. Swanepoel, thank you for presenting your work to us today.
Great, thank you for the introduction, Melissa. It's very good to be with all of you. We're going to switch off the webcams now, just to make sure we don't take up any bandwidth with those. So a good evening to you all from South Africa. I know it's your lunchtime. It's good to be with you. So I'm going to be presenting a little bit of the work that we've done on connected technologies for improving access. And I'm going to present some examples of the applied solutions that we've developed with the research initiatives. So before we get to the presentation, just a quick blurb and an invitation really on the World Congress of Audiology that will be held in Cape Town later this year towards the end of October. And of course, it would be a wonderful privilege to welcome any of you to this special event that will be hosted on the African continent for the first time in its long history since 1952. So just to give you a sense of the simple outline I've put together for today's talk, I'm going to just give us a little bit of background on hearing loss and the global scale of the epidemic. And then we're going to look at the fact that hearing care really is largely inaccessible or at best access too late. And then I'll be ending off with some new opportunities to improve access using connected technologies. And I'm going to just have time to highlight two examples of these types of technologies. So if we just take a step back and we look at the growing global epidemic of hearing loss. These are the latest World Health Organization statistics that were released this year on World Hearing Day. And you can see there that in 2018, the estimate was for 466 million people who had permanent disabling hearing loss. And that means a hearing loss of greater than 40 dB in the best year. So that's a significant number. That's about 6% of the world population. If we include milder losses, that figure jumps up to about more than 1 billion people. Importantly for us to note, when we talk about global hearing care, is that 90% of these people live in low and middle income countries around the world, where access is very difficult and oftentimes totally unavailable. if you look at this map of the world, we can just see a little bit of an indication of the estimates in different world regions on the way hearing loss prevalence will be increasing in the next 12 and then the next 30 years. The important thing to note here is that the biggest growth by far in terms of the prevalence of hearing loss will be in regions like Southeast Asia, Sub-Saharan Africa, East Asia, and East Asia and the Pacific. So hearing loss is increasing, and it's increasing mostly in the areas where we see big population growths. That means low and middle income countries especially will be very hard hit by the increasing prevalence and of course also the poor access to care. So if we look at the burden that hearing loss poses globally, it is identified as one of the major contributors to the burden of disease, even amongst acute conditions. So in 2015, the Global Burden of Disease study estimated that 1.3 billion people are affected by hearing loss. They look at hearing losses that also include milder losses than the WHO. That's why that figure is higher. But important here to note is that hearing loss was ranked as the 4th leading contributor to the years lived with disability scale worldwide. That means hearing loss is an important player on the global health agenda, and has recently also been reinvigorated as such with the World Health Assembly that called for a new resolution on hearing loss, and that was granted last year. It's not only that hearing loss is very prevalent and that it's a great burden globally on the healthcare economy, it's also very expensive. This was from the World Health Organization, and some of the modeling they did indicated that hearing loss accounts for $750 billion in annual costs around the world. And this is for unaddressed hearing loss. So it poses a very high cost to the global economy. In fact, this equates to the annual combined health expenditure of Brazil and China, or the entire GDP of a country like the Netherlands. So hearing loss is very prevalent. It's a burden globally. It's also very expensive. So the big question that we have to ask is, what kind of access do we see people have around the world to hearing healthcare services? Now, this was a survey that was done a couple of years ago. These figures haven't changed much since then. There's been some updated surveys that have confirmed that. Importantly here to note is that the poorer countries are, so the less the per capita GNI is, the less audiologists per million persons around the world. That makes sense. So poorer countries have less hearing healthcare providers to actually provide hearing healthcare services. So those countries with some of the biggest populations have the poorest access to hearing healthcare providers. But even in the countries like the USA, for example, where there are probably the highest rates of audiologists to the general population, there's still a shortage of audiologists to the number of people that will require these services. This was from an article that was published in 2013 that looked at the number of audiologists in the United States compared to the demand for audiograms or audiological services across the country. And you can see that if you look at the predicted growth, or let's say the demand without gaining efficiencies, these are the blocks with the squares. You can see the demand is growing rapidly because of the aging population in the US, especially the baby boomers. So there's a big demand. If we think that there'll be some gains in efficiency in the way audiological services are provided, then we look at the triangles. It's still growing a little bit less rapidly. And then the predicted growth in terms of what current audiological manpower and projected manpower can deliver is much less than the need, and the need is actually growing while the current capacity to deliver these services are actually expanding very slowly. So other factors when we look at hearing healthcare access and challenges, especially in low and middle income countries, has traditionally been that equipment is very expensive. To have the right setup, to have the right equipment can be prohibitively expensive. Also the maintenance cost and calibration. Traditionally also a great amount of expertise is required to conduct hearing assessments. So you need to be trained well, you need to know how to do audiometric testing. There's also efficiency challenges on how we can schedule patients. Audiologists only see one patient at a time. So it means, the number of patients that can be assisted is sometimes much smaller than the need really is. And then, of course, also audiological services traditionally have been very centralized. So they've been based in clinics, hospitals, practices. They haven't really been a primary healthcare service as such. And then finally, delayed access has been in the order of the day, both due to poor awareness. Most people don't know about the profession of audiology in low and middle income countries. And even in some of the high income countries, it's a profession that's poorly known. So those are all challenges to the access, in addition to the number of human resources available. So we have really set our sights on exploring novel solutions in the research that we've been conducting for the last 10, almost 15 years. And we've really looked at how can we leverage some of the current trends in technology, the connected technologies, and also the connectivity that we've seen really drive many of the other industries around us. For example, the mobile money industry has really revolutionized low and middle income countries in the way they bank, or the agricultural sector has leveraged mobile technologies to really change agricultural practices in low and middle income countries. So we really sought a way to capitalize on these big global trends of connectivity and technology. And I'm just going to give us a little bit of background on why we chose this route. Firstly, we've seen this revolution of connectivity becoming a ubiquitous commodity. It has really taken over the world in a very short period of time. I like to use this picture because I always think it illustrates the revolution very well. It's a bushman sitting in the Kalahari Desert with a mobile phone in his hand. You can usually date the year by looking at the type of mobile phone there. It was long before any smartphones were available. And back then, this was meant as a caricature, probably around the turn of the millennium. A bushman in the Kalahari Desert calling his friend, letting him know that there's an antelope on the way and that they need to be ready. But the reality is now the world has changed in such a dramatic way that more than 90% of the world's population today have access to a mobile phone signal. And so it's no surprise that the World Bank made this statement in their report a few years ago, saying that mobile communication has arguably had a bigger impact on humankind in a shorter period of time than any other invention in human history. So that's a big statement. I mean, a big mega trend like this certainly will and has and is influencing healthcare, and should be influencing hearing healthcare as well, for the benefit of the patient and for the increasing reach of our services. This just illustrates this growth in connectivity. You'll see this green line gives you the global population growth since the turn of the 20th century. And you can see that it's grown to just over 7 billion people today. And then we see this light green trend. That's the landline penetration around the world. And you can see we had a significant growth since 1975, and then it started to plateau around 2005, and it's dropping rapidly now because of this new blue trend, which is the mobile subscriptions around the world. And we are now oversubscribed on the planet. We have more mobile subscriptions than we have people on the planet. So that just illustrates how dramatically and exponentially this mobile revolution has changed the world. But it's not just the connectivity that has really changed the way the world works. It's also, at the same time, the exponential growth and advancement in technologies. there's the Moore's law and the growth of computing has stayed true for the last 100 years, showing that the technologies are doubling in terms of their power and or their speed, and at the same time their cost is halved every year. So we see this massive improvement in the computing power, whilst at the same time we see the costs are coming down significantly. So those are powerful trends that are influencing our world. This is from a cover of The Economist that came out a few years ago, highlighting this trend. The title of this edition was Planet of the Phones. And they indicated by 2020, which is just around the corner, 80% of adults will have a supercomputer in their pocket. And that is really what a mobile phone, or a smartphone at least, is. It's a supercomputer in our pockets that we can leverage for all kinds of amazing things, including healthcare. And you'll see the shipments of personal computers on your right, and then the mobile phone shipments suddenly overtaking them, and then having this rapid decline since 2010 because of this new exponential trend, which is the shipment of smartphones. So it's not just connectivity, but it's actually smart technologies that are being shipped around the world and that can be leveraged for healthcare. So the question is, why connected technologies? And the reason we are excited about these technologies, and we really see that they are having and will continue to influence the way in which healthcare in general, but also hearing healthcare in particular, will be delivered, is because they can have a massive impact. And this is illustrated by the quote by Kathy Calvin from the United Nations Foundation, who indicated that mobile phones have the potential to have as big an impact on global healthcare as Sir Alexander Fleming's 1928 discovery of penicillin. So I don't know how many of you have benefited from antibiotics in your lifetime. I'm sure probably all of you. So to equate mobile phones to the impact that antibiotics have had around the world is a massive statement. So there's lots of potential there to really not just give us better technologies to deliver care or to deliver interventions, but really to change entire service delivery models and healthcare systems when we think about the potential that these technologies have. So if we look at this continuum, you can see the cost of care at the bottom of this slide and the quality of life on the y-axis. And the centralized, more tertiary clinic-based services has traditionally been more expensive, so they've been to the right of this x-axis in hospital centers, specialty clinics. And what mobile technology really promises, and connected technologies, is a way to have hearing care move down the cost structure, so we can make hearing care more affordable, whilst we can also make it more accessible as we decentralize services and get them closer to people in communities, in primary healthcare settings, but even into people's homes for that matter. And at the same time, the whole trend is that then we don't even just reduce costs, but we actually can improve quality of life outcomes because we are more preventative in our approach, because we're reaching people earlier in communities in a decentralized primary healthcare fashion. So there's lots of hearing care opportunities by leveraging these technologies. And I'd like to just highlight maybe the entire range of how these technologies can influence our practice as audiologists and hearing care in general. And then I'm going to just focus on really two specific examples that really only cover a certain portion of this range, but that's all we have time for on this occasion. So if you look at this slide, you can see that we kind of have a pathway of care there for hearing loss. Advocacy and awareness first, and then we have detection and the referral of patients or consumers or clients for diagnostics and for triaging purposes. And then, of course, the supply of a hearing device, its fitting, rehabilitation services, and then ongoing support for the individual and the family who acquired the hearing services. So if you look at the top of that continuum, you can see the consumer or the client. When we look at kind of connected technology, for consumers, it needs to be accessible. Of course, it also should be affordable. It should be simple. We want these technologies to be user-friendly, ideally also to be personalized to the person themselves. It should be a convenience-driven service, and it should support a patient or a person's autonomy to be able to make informed decisions around a person-centered approach. If you look at the bottom and we think about the healthcare provider, the audiologist, and their requirements from digital or a connected technology perspective, is that we want these technologies to be efficient. We want them to be data-driven. They should allow for monitoring patients, to do surveillance, to do advanced reporting, and even to direct care. Whilst we can track, we can include things like decision support, and ultimately, it also supports this notion that big data gives us the opportunity to really make all kinds of improvements in healthcare efficiency and optimizations for our services. So I'm going to discuss two examples. I just want to acknowledge the team of researchers and people that we work closely with. We're fortunate to have a wonderful group of international collaborators from all over the world, including Australia, the US, the Netherlands, and Sweden, that we work closely with, and a large cohort of good students, postgraduate students. And I would just like to also acknowledge a disclosure here that the ERX group that provides some of these technologies that have been developed through our research efforts, that I'm a co-founder of this group and also serve as a scientific advisor. So the first example is really taking a consumer perspective with the connected technology. So with this type of technology, which I'll share in a moment, we're really trying to aim towards increasing awareness and advocacy for hearing loss amongst the consumers, whilst at the same time offering a way for early detection of hearing loss and linkage to care or referral to appropriate service providers. So the first example is the HearZA National Hearing Test of South Africa. We launched this 2 years ago. It's a freely downloadable app that can be downloaded on Android or iOS stores, and it offers a digits in noise hearing test free to consumers. We decided when we started this project 4 or 5 years ago to go the mobile route for a national hearing test instead of using a landline like that has been used in other countries around the world. First of all, because landline penetration in South Africa is less than 10%, whilst the smartphone penetration in households is more than 80%. So that made a lot of sense. But more than that, we believe that the mobile technologies or connected technologies like these offer amazing advantages when we want to offer this kind of service. So we had 5 important aims that we wanted to reach with this application. Firstly, we wanted it to be an accurate detection of hearing loss, of course, using a validated digits in noise test. We also wanted it to be a strategic public awareness tool that really should elevate hearing health in the public sector. The third thing is we wanted to bring in personalized hearing health tracking as a concept. We also, for the fourth point there, we wanted to use this as a tool to link persons or consumers who fail a hearing test straight to audiologists. And then finally, we also wanted to leverage this platform as a way to support people through the decision-making process. Some people are just not ready to make a decision, and we thought this platform can be utilized to support them to actually make a decision and go over into action. So if we look at the first component, the accurate testing, we developed this digits in noise test, which is in South African English. We validated it, looked at its usefulness for people who are English additional language speakers, and we published the findings in the International Journal of Audiology and the Ear and Hearing. And really the sensitivity and specificity of these tools are tremendously good. I mean, we have a sensitivity and specificity of 95 and 87% respectively to correctly identify a hearing loss. So we also wanted to ensure that you can use any mobile phone and any type of headphone. So we validated different types and qualities of headphones and earphones. And the great news is that independent of the device and headphone or earphone technology, we got statistically the same set of results. And you can see that with the psychometric curve there. So it really gives you the option to use your own earphones, your own mobile phone, and we get equivalent results across participants. We've also been using a binaural stimulation paradigm. So to your left is a diotic paradigm. So we present the digits binaurally with the noise in the background. Typically for a normal hearing person, you'll get a signal to noise ratio of minus 10 dB. We've recently validated and adapted the stimuli to do it dichotically. So it's out of phase digits that are being presented in background noise. And that gives us an advantage. We're actually getting much better signal to noise ratios that way. And we've done some validation work on the stimuli. And what's really exciting for us, and this information is brand new, is that on the left, you'll see the diotic stimuli presented plotted against the Peotone average, and on the right it's the dichotic. So if you test binaurally, you get the gain of doing the test very quickly. So you do it in 3 minutes. If you want to test ears separately, it's going to take 6 minutes. If you want a consumer app, you want to do it very quickly. So that's why we chose the binaural paradigm, but you don't pick up unilateral losses. But the great thing is that with the new dichotic stimuli, we're actually identifying asymmetric hearing losses and symmetric hearing losses, and we're getting a much steeper psychometric slope. So this is great news. It's actually improving our accuracy of this test, and we're identifying unilateral losses as well in under 3 minutes. The second thing was the public awareness. As I mentioned, we got celebrities to support this drive. So we have had 4 well-known South African celebrities who served as ambassadors, and we did little video skits, really raised a lot of public awareness this way. One of the little videos went viral, and we had more than 400,000 views on that video. So it's about this type of tool lends itself out to be utilized for this type of awareness campaign. We also included the idea of personal hearing health tracking. People are monitoring all kinds of health outcomes and health metrics these days. So the consumer doesn't get the signal to noise ratio. We convert it to a personal hearing score, and you can track your hearing score over time. We send in-app notifications through this application that reminds you every year to redo your hearing test, and you can compare it to the previous year's score. There's also neat little things to engage a younger audience, so you can share your score or challenge a friend on Facebook or Twitter to also do the test. And there's a scoreboard where you can see your score against your friends or other celebrities that have done the test. Important for us was that we don't just want to detect hearing loss, but we want to connect people to audiologists. So we partnered with the local associations in South Africa, populated a database in the back end. So in the application, once you fail the test, you can see a list of audiologists that are closest to you. You can also request the audiologist to contact you. You can log your details, and they get an email. They log into a secure system, and they can contact you to arrange an appointment or to do a telephonic consultation. So here's just an update of some of the results for the first 18 months or so that we had this test live. So we had just more than 35,000 people do the test. 32% of those who conduct the test actually fail it. So certainly there's a proclivity for people who have a hearing problem or think they have a hearing problem to do this test. Of those who failed, 15% actually included their details and asked that an audiologist contact them. We don't know how many actually looked up the details and contacted the audiologist directly. Of course, we'd like to have people who fail the test connect with an audiologist, even those who may not be ready yet. So we worked with the IDEA Institute to include a decision support tool. So if you fail the test and you're not quite sure if you want to connect to an audiologist, you can do this 2-minute interactive guide, Why Improve My Hearing, and it runs through some of the IDEA tools that's been adapted for a mobile version. To really support the decision-making process to follow up with hearing healthcare services. So we have partnered with the American Academy of Audiology, and we launched or revealed the application at the CAA event in Nashville earlier this year, signing up audiological practices through the American Academy of Audiology, and the app is scheduled to be launched in the summer of 2018. Importantly, this app will have the same features, but will have some additional features in there so that someone who fails can, for some practices, they can actually make a booking directly from the application. So we're hoping that will also increase the uptake of audiological services from there. So maybe just to quickly talk about adaptations of this digital noise test that we have developed and are currently also evaluating on pilot programs. We developed a web application that offers this digital noise test so that audiologists can literally incorporate this web application into their own practice website. So when someone comes onto the website, they can take the test. If they fail it, they can log their details, and the audiological practice is notified. So it's easy integration, and it also includes this IDEA decision support tool. And it's a way for audiologists to really use the connected technologies to get people to refer to their practices for their services and to increase awareness around hearing loss. The same technology has been adapted to a kind of kiosk format where it's being used in community placements like pharmacies, physicians' offices, optometry offices for corporate and wellness screening. So it's a self-test. Someone walks up to it, they do the digital noise test, they get the result, and they can also request to be connected to an audiologist through the application. So it's used as a referral to audiological services. So these are just useful adaptations to actually take it the consumer model a little bit further. On the one hand, to the audiologist's website, but in this example, actually as a primary healthcare approach to decentralize, get it into other offices and community venues. So that's the kind of consumer example I wanted to share with you. The next example here is really a primary healthcare example of how we can use connected technologies to detect hearing loss in an efficient and affordable way, and link them to diagnostics, and then ultimately also to audiological services for intervention, fitting, and rehabilitation. So we I've spent a number of years developing an Android application called HearScreen that links or connects to a calibrated headphone, and that changes this to a screening audiometer that can be operated from a mobile phone. But what's important for us about this is that it's a tool that's developed to be extremely simple so that anyone can operate it. We developed it with the idea that people who are illiterate should be able to operate this and conduct screening tests. Also, it's connected to a cloud-based data management service. So remotely, audiologists or other health professionals or practices can actually monitor all the results that are coming in for quality, and then also for reporting purposes and referrals through text messaging or email. So the HearScreen technology has been validated and published in a number of journals to ensure that it's accurate, that it adheres to audiometric standards. It's an audiometer that runs from a smartphone. The test paradigm ensures that it's very time efficient. We use low-cost Android devices to make it accessible and affordable. And then we use quality control measures like the continual monitoring of the environmental noise using the microphone of the device, and to track the quality index of the test operators. We have some false positive test instances. So when someone presents a tone and a child indicates that they heard a tone and they say yes, in some instances when they present the tone, there's no presentation actually. So if they say yes, there was a response, we know there's a training or some kind of quality issue with that test operator. And it's been developed so that laypersons from the communities can actually operate this technology. So I'm going to take you into an example project that we did. This is one of our first projects that we utilized this technology for early childhood development center testing for young children between the ages of 4 and 6 years. We did this in a community called Mamelodi, which is a very poor, underserved community in South Africa. We did this in partnership with the Innovation Edge. Here is Charles and his mother. His mother owns an early childhood development center in Mamelodi. Charles was unemployed at the time we started this project, so he was our first community member that we trained to actually conduct the screening. The first thing we had to do is actually map where all the early childhood development centers were. So these are little informal preschools that families have where kids come during the day when parents go to work. So we literally had to have our 3 screeners from the community walk through the community, map out all these informal early childhood development centers. It's mapped on the application, so it syncs back to the cloud-based data management service. And so this way we can also do smart planning around the number of kids, which facilities are close by, and that we can coordinate the testing with. So we mapped close to 300 of these facilities. And then the next step was to actually conduct the screening. So we had 3 community members trained as screeners. They did not have any tertiary education. They only finished high school. Here you can see Charles testing a young girl in one of the early childhood development centers. What's important to note here is that Charles is doing the testing using a forced test paradigm. So it's automated, so we use automated test sequences in the test protocols. So you don't need to know how an audiometer works. And the other important thing is that it includes the quality control metrics that can be monitored remotely. So we had audiologists monitor the results as they came in. If the quality index of the test operator dropped below a certain amount, they retrained. And at the same time, if a child fails a test, a text message is automatically generated from the cloud-based service with the result and is sent to the parent with a referral to the local clinic for a follow-up appointment. So that way, it's not just about detecting the hearing loss, but actually automating the reporting and connecting them to a center of care. So they were referred to the primary healthcare clinic in this community where we did have an audiologist. They had the Big Brother of the Ear Screen app, which is ear test that actually determines a audiogram. So when a child like this arrived at the primary healthcare clinic with the referral, the audiologist would look up the name in the database on the phone. They can review the test results, and then they can action a audiometric test for an audiogram. And all of this is captured in this way. We also know which of the children did actually attend their primary healthcare clinics, and that way we know which ones to follow up on. So it's the power of a connected technology for data management, surveillance, and also referral and reporting. And then, of course, those who identified with hearing loss were fitted with hearing aids. For this particular project, we screened just less than 7,000 children. 503 of them were re-screened at the primary healthcare clinic, and 180 of them were confirmed with hearing loss and were received hearing aids, and some of them are still in the process of receiving hearing aids. Just an interesting side note is, as we delivered these services, the one question we often got was, what about vision? It's great that we can deliver hearing care services, but what about vision loss? And because that's also an important barrier to educational success for young kids. So we partnered with a group from the UK that were from the London School of Hygiene and Tropical Medicine that developed mobile technologies for vision testing that are literally doing the same as ours for hearing, that theirs are doing for vision. And we incorporated their technology into our platform, so that you can, on the same patient, do a hearing screening and you can do a vision screening, and you need very minimal training to actually do this kind of testing. So just an interesting note on how we're expanding this work. We now have several other projects that we're running in different communities in South Africa, but also in other parts of the world, where we're refining the model. One of the exciting ones is one we're running in Khayelitsha, which is a community outside Cape Town, where we're screening 10,000 children between the ages of 5 and 6 years at these early childhood development centers. They're getting hearing screening and vision screening. We've refined the protocols a little bit to get referral rates down and to get false positives, also to minimize those. And these are just some of the early results that I can share with you. So for hearing screening, up to date, we've screened 4,188 kids. The referral rate has been 6.4% for these children. They get re-screened, and then the final referral rate for diagnostic services is 1.6%. So it's really very low. And to date, we have identified 19 children with hearing loss from this group. Out of 43 who had diagnostic testing, there's still 10 pending. And of course, we will be testing up until 10,000 children, and then we'll see how we can take that further to make the program sustainable. In terms of vision screening, the same amount of kids have been screened. The referral rate was 2.2%. We've identified 5 kids with vision loss that are receiving glasses. From 16 who received diagnostic testing, there's still 75 pending that still need to get their diagnostics testing done. There's just a little bit of a service delivery backlog for the optometry services at the moment. But that just illustrates some of the possibilities of these connected technologies to really scale hearing and vision screening into communities using laypersons with remote quality control over a cloud-based data management service. And if you're interested to have a look at a quick little video, 2.5 minutes on this program, you're welcome to go to this link and just have a quick look at how the technologies operate and what the impact is. So in conclusion, hearing loss is a major global health problem, and it is largely inaccessible, especially in low and middle income countries where we know less than 3% of people who can benefit from a hearing aid actually get it. And connected technologies really offer a powerful way of enabling hearing healthcare access. And new models for access can improve not only our reach, but also our efficiency in the service delivery, and ultimately the impact that we can have on populations globally, and especially in low and middle income sectors. And it is an imperative for us to bridge the gap between this pervasive need for services and the limited and delayed access that currently is the reality for most people with hearing loss around the world. These technologies also offer, the future potential to optimize our services, to personalize us, and also to manage this hearing healthcare pathway in innovative ways, right through from detection through to intervention. So it's an exciting field. We believe audiologists should be at the center of this to really direct this kind of development and to support it as we position audiology and hearing healthcare in the public health and consumer sector as well. So I'm going to end off there. I think we may have some time for questions, and I'm going to hand over to Melissa to handle that part.
Okay, thank you, Dr. Swanepoel. We are now going to answer some questions submitted during the presentation. As a reminder, you can still submit questions to the question panel or pane in your attendee control panel. So we will still be accepting questions. So the first question we have for you is for the other venues. So you had talked about the Here kiosk and the different community offices. What was the response rate of these community centers to accepting this technology, or how difficult or was it to implement this?
Yeah, so that's an interesting question. Look, we have done a large partnership with an independent pharmacy group in South Africa who have rolled this out to the pharmacies. It's been a tremendous value add for them. They are seen as, you know, a hub for communities to get healthcare information. There are small clinics, and now to be able to offer a hearing screening service as well as a kiosk has been very beneficial from their perspective in terms of the public's view of the service. So the uptake has been very good. We've also seen that the initial analysis show that, you know, the people who take these self-tests usually, I mean, it's almost about 40% of them end up failing the test. So people who think they have a hearing problem are actually confirming it with these tools. So that uptake has been great in general practitioners' offices, physician offices. There's also been a lot of interest. And patients who sit and wait for long periods can now, you know, spend a little bit of that time actually doing a hearing test. And in fact, the interesting side note is that one of the largest general practitioner offices in South Africa has one of these kiosks, and at some point, one of the physicians actually tested themselves, and they failed the test, and they went to the local audiologist, and they were actually identified with an acoustic neuroma. So that was and so now that practice is extremely motivated to ensure that, you know, their patients are actually tested through that. So the response has been very positive.
Okay, great. So some questions are coming in here. So we have from Dominique. I think this is in relation to one of the earlier apps. She was asking, shouldn't it be called a hearing screening and not a hearing test, or that type of test?
Yes, it is referred to as a screening test. So I don't know, maybe at some points there was a mention of a test, but it's obviously it's referred to as a screening test. You know, it gives a yes/no answer. On the patient just gets an interpretation of, you may have a hearing problem or a hearing loss, or your hearing seems to be okay. So yes, certainly it is a screening test. It's not a diagnostic test.
Mm-hmm. And then from Renee, we have, how do you manage the audiological review portion of HearScreen and your other products?
So the review by audiologists, really, it's a telehealth kind of model or an e-health model. So they have access to the cloud-based data management portal. They can see individual test results for persons tested. They can also see the quality of the test operators, the number of persons they tested. They can also see the quality index that I mentioned to you. They can also see the noise levels in the environment. It's very important to do good quality control if you're doing community testing by community members or lay persons. So we need to know that what's happening there is actually reliable. So the quality control is very important. And all of that can be accessed from a dashboard from a cloud-based data management system called mHealth Studio.
Okay, and we have another question. So you have the audiological app now, the Hear Test. Is that going to be integrated with bone conduction capabilities, or right now is it mainly the air conduction abilities?
Yes, I mean, the idea here is not to offer a full diagnostic suite. I mean, for that, you know, when it comes to a medical kind of or an audiological case that's difficult to test, then of course you need to have a full bone conduction testing done as well. It's really intended for primary healthcare settings. So no, it's not integrated with bone conduction. It's not intended for audiological clinic inside a soundproof booth necessarily.
Okay. So is your, this is a follow-up question from Renee, is your iCloud product certified for privacy use in Canada, and where is the data stored?
Yes, so that's, I mean, for every country has its own requirements, right? So yes, the data management, when it's in Australia, it has to adhere to their e-health record requirements, and the data has to be stored on a server that is located in Australia, for example. And if we do projects in Canada, the same will apply there.
Okay. We also had a question. So in your initial study that you did. And what location were most of your responses coming from? Were they more from cities, or did you have a wide response across South Africa? And what age groups were you able to capture? Was it mainly young adults or across the range?
Yeah, that's an interesting question. So we haven't looked at these analyses in detail in terms of where the tests were conducted, but for the majority, they came from urban sectors. So it's just more than 50% of people in South Africa stay in urban sectors. So that was expected. A lot of the kind of press and the media that came out was also situated in urban centers. We use digital media campaigns to get people aware of hearing loss and of the national hearing test. In terms of the test or the age of participants or people or consumers who actually use these applications, the interesting thing was we got a big sample of younger persons. So about 50% of people who did the test were younger than 45 years of age. And the other 50% were above 45 years of age. So we really did get a big group coming from much younger populations than we usually get with screening tests.
Which is interesting because you still had 32% fail the test.
Yeah.
Okay, so we have a question from Seema. So in low middle income countries, there can be a high number of outer and middle ear issues. Have you integrated your smartphone otoscope into these technologies?
Yes, so we didn't have time to speak about the earscope, which is the smartphone otoscope that connects to the device as well. But yes, all of this is integrated into the same platform. So if you do a hearing screening or an audiogram, or you do otoscopy, take an image of the eardrum, they're all appended to the same patient record and uploaded to the cloud, yes.
Okay. See. I don't see any more questions coming in. I did have another question. What kind of noise is used for that digit in noise test?
So we use a speech-weighted noise. So that's typically used with the digits in noise test. So it's speech-weighted for our particular set of digits, which increases the difficulty level, and it's weighted according to that speech weighting. Yeah, so that's the type of noise we use.
Okay, and so we're nearing the end. If there's any more last minute questions, I think we've got that. Oh, we do have another question. Sorry. Are instructions in the app in English only? Can this app be downloaded elsewhere in the world, so non-English speaking countries, through Android Play Store, and can instructions be easily understood by users to start the hearing screening?
Yes, so the Hear ZA app, which is a consumer app, it's intended for South African use. So the last I checked, it was only open on South African app stores, Android and iOS. But it's in English at this stage, so that it's only supported in English. The other applications that are the primary healthcare applications, we support English, but we're also supporting other languages like Spanish for the ear test. And the idea is, of course, to grow that support into other language options around the world. The whole idea is that it should be accessible, and that language shouldn't be a barrier.
Okay, and then we have a question. Can you just remind us the names of the apps? Just a quick review. Someone wanted a quick review.
Yes, so the screening application that really is a quick ear-tone audiometric screening is Hear Screen, one word. The one that does a ear-tone audiogram air conduction is called Hear Test, also one word. Someone mentioned the otoscope, it's called Hearscope. And then our consumer app, that's the National Hearing Test of South Africa, is called Hear ZA.
Okay, and all of these can probably be found on the website that you had provided as well, right? The Hear website. Great, well, I do not see any more questions. So think we'll wrap this up. I'd like to thank you for the wealth of information. Is very interesting in this day and age, how audiology is changing and access. It's quite exciting. So thank you for showing all the great work that you're doing. I'd like to just, we are grateful also for all the participants of our webinar. If we can go to the next slide here.
Sure, there we go.
I'd just like to remind everybody that our next CAA webinar is on motivation, cognition, and listening effort with Dr. Mary Rudner, and this will be held on June 28th, 2018. So please register today. Registration is open. And the learning objectives are the role of cognition and listening, understanding the framework for understanding effortful listening, so FUEL, and methods of measuring listening effort. And then we also have a reminder that the Canadian Academy of Audiology Conference and Exhibition early bird registration runs until June 12th. And this conference will be held October 17th to 20th in Niagara Falls, Ontario. And CAA members can receive a discount on registration. And then finally, we would like to again thank Dr. Swanepoel and everyone for attending today's webinar. This webinar has been recorded and will be posted to the website within 1 week. We ask that you take a moment to please complete a short survey after this webinar, which will help us inform how to run these in the future. And the contact information here is for the Canadian Audiology.ca, and you can see our website, and then also any questions to contact at CanadianAudiology.ca. And there are lots of ways that you can subscribe and get involved as well. So on behalf of the Canadian Academy of Audiology, again, thank you for joining us today and have a great rest of your day.